So while they're pulling me up, let me just go ahead and say thank you very much for having me here today. You can probably tell I don't do this a lot. I'm kind of the opposite of Dr. Katinka. I'm usually in the back. I live in my lab. I've always got my head in files. But there is a certain responsibility that comes with the knowledge and the people that we work with, the need to share not only with the patients still out there, but with other providers and maybe the person with the other piece of the puzzle. So everything that I'm going to share with you today comes from my experience in dealing with these patients and looking at their files. In our last count, and we have lost count, we need to go do that again. I think I've looked at 300 files of people with CRPS. Now, that is not the EDS patients, it's not the other pain conditions that we work with. But you start to see patterns. And with that, you start noticing certain things. Now, I'm not the most clever person out there, but if you see the same thing over and over, like that red spot there behind the neck. Now, I have two practices. I have my local practice, and then I see Dr. Katinka's patients. And that is kind of an unusual thing that you see in maybe 1 of 100 people. But then when I work with her people, about 1/3 of them have that. And after a while, you have to say, what in the world is this? And you would ask them, and a lot of the girls don't even know they have it, or they'll say, it's always been there. My mom said it's a birthmark. And so with the blood labs and all of the physical findings, we start seeing this line going through the case files of people that live across the world that's never met one another. You can't make this stuff up. So today what I'm going to do is we're going to talk about just 2 things. I'm aware that I'm the only thing standing between you and lunchtime, so I'm not going to hold you up. We're going to talk about infections and why it's important, why it's one of the first things we do. So my main job in the clinic with the chronic pain patients, I look at the files, I remove the obstacles to treatment, and then before they go home, we make sure that recovery stays. Because it's one thing to fix something, it's quite another to keep that thing fixed, isn't it? That is the worry for all of these patients. So, infections, why do we care? I started with the fact that we know it increases inflammation, it increases pain sensitivity, it acts as an autoimmune accelerator, and it slows healing. The main thing is that it slowed the treatment. These people would come in with infections, and the therapist, as soon as we hook them up to any kind of electric current, as soon as we push up their heart rate, would come to me and say, there's something wrong with this person, they're not going to do well. We have to stop treatment and do this first. And so what we see, and I'm sorry for this photo, it's gut-wrenching. We're going to call him patient A. The foot there on the left was at the beginning of treatment, and you can see how hard that would be. That is a person that cannot wear a shoe, they cannot stand. From a physical therapy, from a chiropractic standpoint, it severely limits what you can do with this patient. Now, this was a team effort. I'm not by any means going to claim that this was my success. It's a group of people working together. Middle was halfway through the treatment. The foot on the right that I'm proud to say was just last week. So about a year out of treatment, correct? Now for this patient, his infection was interstitial cystitis. Are you guys familiar with that, what that is? Now, it's something that we find a lot in females, very rarely in males, but in the population of chronic pain patients in our males, we see quite a bit of it. And you're thinking, but my labs are normal. So the traditional medical definition of infection is there has got to be an elevated white blood cell count. You have to have the fever, and then you have an infection. And if you have some kind of a rash or a symptom somewhere else, it really helps them kind of figure out what kind of infection. Now that is not true for chronic infections. And so something I want all of you to do is go pull up your old blood labs when you go home and look at it. With chronic infections, the white blood cell count will actually drop. It'll oftentimes be below 5.0. And we look at the neutrophils, the lymphocytes, and the monocyte count there. So it's supposed to be 60, 30, and 7. If your neutrophil counts go up, that 47.5 is supposed to be 60, but it's lower. And then this guy, the 39.2, is supposed to be 30, so we know that is a viral infection. It kind of narrows the field of where we have to go look. Sure. And if you guys have labs, I'll be happy to look at those for you. It's very stable across, yes, ages, sexes. It's supposed to be 60, 37, and the last 3% split across. Can I move on? Eosinophils and basophils. And so, by the way, if eosinophils go up, we know you've got allergies or food allergies, food sensitivities. We test for those. Basophils, nobody knows what they do. If you know, let me know. So chronic viral infections, we've already gone over that. The one that we see most commonly in our practice is the Epstein-Barr virus. Now, you guys know that as the monovirus. It's something that 86% of the population tests positive for. It is supposed to be a no big deal. But because of genetic variances in patients, some patients with the chronic version of that, all of these diseases have been linked to chronic EBV infections. Now, when they do the EBV IgM test, or what they call the spot test, it just tells you if you have mono right now. What you want to request is the antibody panel. And that's the Quest Lab test number, and we want to look at the viral capsid antibody count. So for a normal person, after you get the virus, that number would be somewhere in the 300 to 400. So it stays high for the rest of your life. For patients with a chronic issue with this virus, it's oftentimes 500, 600. In our worst cases, it dwells in the 700s. Now, I thought I was clever when I figured this out. And then I ran across this guy's research. This is way back in 2013. He did a paper on the vagus nerve and what he called neurotropic viruses. So these are viruses that live inside the nerve system. And what he described, it causes chronic fatigue syndrome was really his area of expertise. But he also noticed that it had a hyperinflammatory cytokine response and what he called the exaggerated sickness response. Kind of sounds familiar, doesn't it? Now, other viruses that are nerve-loving, that live inside the nerve, is the cytomegalovirus, the herpes 1 and 2, the Coxsackie virus. So Coxsackie gives you hand, foot, and mouth. It's a toddler disease. It's something so harmless that we get as kids. And we're supposed to get over that and move on. Now, the vagus nerve is called the wandering nerve. My theory is that genetic variance alters the immune response. And then we get infections that attack and infiltrate that vagus nerve. And the body starts attacking that nerve. And then you get slight organ, body region dysfunction that lingers there for years. And it smolders, it sits, it waits. And so when you have a concussion or injury to a nerve, and that nerve starts degenerating or regenerating, the body will then attack that area, that there is a certain autoimmune aspect to this pain. Now, unfortunately, through some medical studies, we do know what the vagus nerve innervates, and we know this because what happens when you cut the nerve? What do we see in these people? And I'm not going to read this to you, but read this and see how much of this overlaps these conditions. And this is where you go, wow, we're onto something here, because this encompasses my patients. This is what we deal with. And typically, these people are told, you're just really unlucky. You have all of these comorbidities, and they each have their own diagnosis, and it's so complicated, you're so unlucky. But no, it's all a part of the same thing, the same progression. So, this is my viral treatment. That's it. It's simple. We do the zinc, selenium, and monolaurin. Now, a note on the monolaurin, you're not going to start at that dose. And no, you're not going to do it on an empty stomach. You're going to wait for after lunch. You start very slowly. And if you're not sure why, go ahead and have the full dose. You'll figure it out. We have tried many of the virus-specific formulas. I've moved away from that. We don't do the blood testing for that. I don't care. This works on most of our patients. Now, bacterial infections also definitely come into play. Antibiotics, why do they fail today? First of all, you may have been given the wrong antibiotic for the problem that you have. The other thing is antibiotic resistance. I don't need to talk about that. And then antibiotics work on cell walls. So if the bacteria that you have either don't have a cell wall, or they're hiding behind this biofilm, antibiotic is not going to work. They can put you on IV antibiotics, and we get a lot of patients that have been there. It's not going to work. Now, what it looks like in practice, and I promise this is the last gross photo, but the patients with the bacterial infections look a little bit different than the viral ones. They get very quickly what we call chemical burns. They respond to water sometimes, especially electric stimulation, where they get spotty like this. And so you start seeing a bunch of these now, just on visual. I can usually say, let's do bacteria first. So the infections we look for, sinuses. We see a lot of those in our practice. Interstitial cystitis, 50% of that is asymptomatic. You're not going to know you have that. And a box of test strips from Amazon, I think, is $10. You need to know if you have a urinary tract infection. We see a lot of lung infections, the tick-borne diseases, of course, teeth and gum to a lesser extent. We don't start there. We start elsewhere. Now, the bacterial protocols varies by infection. It's not as simple as the viral stuff. The sinuses, I can tell you, biologic medicine, those people are more clever than we are with that, so we usually refer out for that. The UTI protocols, no, we don't use antibiotics at all in my practice. We only use natural substances. And then for all other infections, we use biocidin. The company is Biobotanical Research, if you want to go look into that. It works like an antibiotic. It's basically a biofilm remover. And I'm a big fan of this company. Oh, the iron levels, we don't fix those. If somebody's got a bacterial infection and they have low iron, you need to check their ferritin levels. It's usually high. Sometimes it'll be low. But don't give that person iron. It's a way for the body to control the infection. If you give these people an iron drip, they will oftentimes have an autoimmune flare. It's all of a sudden that infection has got the oomph to start growing, and then you have a problem. Now, sometimes if we have a hidden infection that I really can't find, I'll give them a little bump of iron, and they'll come back and say, it's bacterial vaginosis. I found it, I know where it is now. Or the sinuses will flare, and then we can treat it. But as a rule, we don't supplement iron before you control the infection. Can it be both? Yes, often. So when in doubt, treat for both. Now, just before I take questions, low yield test. I'm not saying these tests are useless. Please don't misunderstand me. These are tests that I see dozens and dozens of in our population of patients that are negative. Now, I understand why the doctors want to do them. It's a good medical practice. But if you are fairly sure you're one of our patients, these are low-yield tests, probably not going to find anything. Save this for later when you've exhausted other avenues. I cannot tell you the amount of MRIs we have to see of the same limb. So if you've had an MRI, take that MRI to different specialists, but don't go over and over and do the same thing. As far as the tests we like old stuff. I have to work with a lot of old stuff. A lot of the people that come to us are not needle ready. So yes, I'll go back 10 years in your file if I have to. I can oftentimes tell you which year the infection started. And when you say that to people, they'll say, yes, that's when things change. I didn't have the condition back then, but that's when things changed. Any questions? This one. Yeah. Yes, and Katinka will talk about this a little bit more. I am here in the back. I'm not a public speaker, but I want to teach this. And I don't want to just teach this to people, and my patients will tell you, I teach them how to read their own blood work. You can't just go to your doctor and go, am I normal? For one thing, they don't know. So next time somebody reads blood work to you, cover the file and say, what is normal on that test result? What should it be? They may not know. They work with clinical ranges where they take the 5% high and the 5% low, and that's abnormal. And if you're on the 90 percentile in between, we're going to call you normal. Where you can go to them and say, look, you can call me many things, but don't call me normal. Yes, ma'am. Sure. Yeah. Yes. Not always, but yes. If there are no nitrates, no leukocytes, but you still feel like you have to urinate, you've got all of the symptoms, that is more of an autoimmune version of it. We see a lot of bacterial vaginosis. And in the beginning, I drove myself crazy. We would send these people to gynaes, get them swabbed, get it sent off, and it would come back normal. And they would say, I'm going crazy. I know everything is not okay. That is a part of the vagus nerve actually goes to the uterus and to the ovaries. And that's why we see these estrogen, vaginal wall, bladder issues with these patients. So sometimes that is more a part of it needs to be treated, to answer your question in short, like an autoimmune condition. And there are many people out there that are good at treating those. And I'll be happy to talk to you afterwards, give you the name of some products you can try. Yes, ma'am. Yes. Yes, and it is not this lightning strike. We see this problem pop up in families, so I know genes has got something to do with it. I would like to get this thing resolved to the point where we can screen for this, you know. If I have a daughter with a mark on the back of her neck and the gene snip, I'm not going to allow her to drive an ATV. I may not pick cheerleading for her as a sport. We need to get to the point where we lean into the future of this condition instead of saying that, yes, this is real. We're past that point. Everybody knows it's real. How do we solve it? How do we screen for it? How do we cut the treatment times and the costs put towards this short? How do we simplify it? I want to thank you so much for having me out today, and I hope all of you enjoy your lunch. I'll let Philip do the last words here.